for participating in the session. I wanted to welcome and introduce the co-chair of the session, Dr. Sarah Delire, a clinical microbiologist, subspecialized in medical mycology in Paris, France. And today we will be discussing the rapid culture-independent diagnostics, charting the new course for sepsis management and antimicrobial stewardship. I would like to hand over now to Dr. Sarah Delire.
Thank you very much. So we'll have a panel discussion and Q&A session at the end. So we're going to go straight to the next speaker. So I have the pleasure to welcome Dr. Thomas Walsh, MD, PhD, which serves as a professor of medicine, pediatrics, and microbiology and immunology at Cornell University, and is the founding director of the Transplantation Oncology Infectious Disease Program. So today we're delighted to have him with us to talk about advances in molecular diagnostic strategies for detection of sepsis caused by multi-drug resistant pathogen in critically ill and neutropenic patients.
Thank you. There is a slight delay in advancing the slides. Okay, here we go. So these are the list of my disclosures. So today we're going to address the pathophysiology of sepsis. We will address the role and critical role for early and rapid diagnosis of sepsis and the potential for non-culture-based systems for aiding and facilitating the early detection. So we can begin with what is the pathophysiology of sepsis? This is imperative, for sepsis is defined as the system's immune response to severe infections, including those caused by bacterial, fungal, or viral pathogen-associated molecular patterns, so-called PAMPs, leading to tissue injury, organ failure, and death. At a cellular level, the lipopolysaccharide of gram-negative bacilli or the peptidoglycan of gram-positive bacilli activate toll-like receptors to trigger NF-kappa B transfer to the host nucleus, resulting in transcription of immunomodulatory cytokines and pro-inflammatory molecules, including IL-1 beta, TNF-alpha, and IL-10. Both organism-mediated injury and host inflammatory damage then contribute to the release of host molecules. These are known as danger-associated molecular patterns, DAMPs, that effectively paralyze host response to microbial pathogens, further facilitating the relentless course of sepsis. The result is that one has a multi-system pathophysiology, starting at the cellular level at endothelial cells, revolving rapidly and impacting on the coagulation system, the lungs, injury, with ensuing events of disseminated intravascular coagulation, acute respiratory distress syndrome, and renal failure, even within hours as sepsis is evolving. So that the destructive cascade of events ensues without diagnosis or treatment, results in progressively severe cellular and tissue injury, irreversible organ injury, and potentially fatal multi-system failure. A key to abrogating that process is rapid molecular diagnosis of sepsis. We then need to ask, what are the culture-independent tests for bacteremia and candidemia? With that, we have procalcitonin, several PCR systems, next-generation sequencing of microbial cell-free DNA, 1,3-beta-D-glucan, mannan antigen and antibody, and T2 magnetic resonance. Many of these systems may provide rapid, some may be delayed, but we will focus today in our discussion on T2 magnetic resonance as a model for culture-independent tests for bacteremia and candidemia. If we look at the T2 biosystem, as Dr. Abuja had just discussed, one can receive results within 3 to 5 hours of blood draw. There is no sample preparation. The analytical sensitivity is down to 1 CFU per ml. And looking at T2 candida, T2 bacteria, T2 resistance, they offer the potential for rapid detection of at a level of sensitivity for T2 Candida of 91%, specificity of 99%, T2 bacteria sensitivity of 90%, also specificity of 98%, and T2 resistance is still in the United States undergoing regulatory clearance, but I will nonetheless discuss our findings in European collaboration. So if we reflect on T2 Candida and rapid detection of candidemia, we find that the T2 Candida pivotal clinical trial, again, found 91% overall sensitivity, a high degree of specificity of 99% across all of the species of albicans, parapsilosis, crucei, glabrata, and tropicalis. If we then look at the impact, most critically, of time to diagnosis, T2MR was shown to lead to a greater than 7-fold reduction in time to appropriate therapy, i.e., 5 hours versus 39 hours prior to implementation of the T2 magnetic resonance. The median time to appropriate antifungal therapy reduced from 39 to 22 hours, and Candida was definitively identified in 93% of patients. Notably, one can also see a significant reduction of Candida ocular involvement from 30% to 12%. And T2 Candida is also more sensitive than conventional blood cultures for detection of deeply invasive candidiasis. Dr. Milanakis reported first the detection of intra-abdominal candidiasis in a case report of more than 12 negative blood cultures, but detected by T2MR on day 0. Subsequent proven Candida albicans was found at surgically obtained tissue culture. 29 other episodes were reported in this study, of which, for example, 5 had confirmed microbiologic evidence of Candida with negative blood cultures and positive T2. Further amplifying this point, we see the T2 Candida assay in a recent report of Journal of Fungi this year found that T2 Candida, and notably also beta-D-glucan, were sensitive in detecting intra-abdominal candidiasis before positive blood cultures. Further to that point, in a recent paper in Open Forum in Infectious Diseases, T2 Candida and also 1,3-beta-D-glucan also were more sensitive than blood cultures in detecting intra-abdominal candidiasis. If we reflect then on T2 bacteria and rapid detection of bacteremia, we first should examine the T2 bacterial pivotal study, which enrolled 1,427 patients in screening for A. baumannii, E. coli, ECCMID, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Staph aureus. The primary endpoint on that study was the paired draw of T2 versus culture identification. The blood culture and T2 bacteria results were positive for targeted bacteria, respectively, in 3% of patients with positive blood culture, 13% with T2 bacteria, indicating a greater degree of sensitivity with no loss of specificity. The mean times from positive blood culture to positivity of identification of organism were respectively 38 hours versus 72 hours. By contrast, with T2 bacteria panel, the mean time to species identification was 3.6 hours, a significant reduction in time to identification. In our own study, if we examine the T2 bacteria panel for rapid detection of bacteremia as a potential guide to therapy in neutropenic patients with hematological malignancies and stem cell transplant recipients, among 84 patients with hematological malignancies and/or stem cell transplant, of the 5 pathogens detected, 14% was positive by T2, 5% was positive by blood cultures. Among the 8 cases that were T2 positive and blood culture negative, 3 were caused by E. coli, 2 by Faecium, and 3 by aeruginosa, common pathogens that are known to either translocate or to also infect our neutropenic population. Importantly, the median time to species identification for T2 bacteria was 3.8 hours. in contrast to 7.8 or 48 hours than that for blood culture identification. If we then ask a further question, what is the impact of molecular detection on detection of escape pathogens and antimicrobial stewardship? We see that the diagnostic performance of simultaneously collected blood cultures for and the T2 bacterial panel in sepsis resulted in considerable documentation and detection of the key pathogens, both for proven blood culture infection, for proven and probable and possible bloodstream infections. Again, confirming, reinforcing the original 2019 report on the T2 bacteria study. If we compare on-panel pathogen detection in that study of T2 bacteria versus blood cultures and T2 bacteria panel detected, we find that 94% of 17 proven and probable bloodstream infections were detected, in contrast to 53% of 17 detected, as seen here in the right panel. One of the potential areas requiring advance is the rapid detection of microbial resistance. Even though we may be able to detect organisms, whether they are susceptible to existing or current antimicrobial therapy remains a challenge. With that, the T2 resistance panel has been an important advance in rapid detection. To exemplify this, we conducted a prospective observational study of T2 resistance system for the detection of resistant genes in bloodstream infections in a prospective clinical trial in two major medical centers, University of Perugia Medical Center in Perugia, Italy, and Evangelismos General Hospital in Athens, Greece. Over 5 months during the time at which T2 resistance was being utilized in detection of bloodstream infections in patients. The system is able to detect KPC beta-lactamase, CTXM 1415, the metallo-beta-lactamase, NDM, VIM, and IMP, OXA48, VAN A, VAN B, MEC A, MEC C, and AMP-C. The mean time to T2 resistance was 4.4 hours for all enrolled patients. The mean time for T2 resistance at the University of Perugia for detection of resistance in positive blood cultures was 33%. For Evangelismos, where 3.6 hours was the time for detection in comparison for the final reporting of positive blood cultures with antimicrobial susceptibility testing was 101. To the right, you can see the impact of T2 resistance. In the first 3 bars, one can see extended periods of time ranging from 35 to as long as 117 hours for results of conventional phenotypic observations and identification versus time to positive resistance ranging from 4.25, 4.15, and 4.35 hours. The mean time to a positive result from the standard molecular resistance assay for blood cultures was 34 hours, and for immunochromatographic CTXM was 27 hours, in contrast to that, once again, for T2 resistance panel, which was approximately 4 hours. So when monitored for the impact of significant antibiotic changes at Evangelismos, there were 22 events of discontinuation of unnecessary antibiotics and 10 events of escalation of antibiotics, underscoring the value of rapid identification of circulating circulating resistance molecules. So in summary, the pathophysiology of sepsis results in rapid cellular injury, tissue damage, and organ dysfunction, resulting in high morbidity and mortality. Early diagnosis and treatment are critical for successful outcome of sepsis in critically ill patients. and rapid molecular diagnosis by T2 Biosystems may guide accurate and rapid detection of bloodstream infections as a guide to targeted antimicrobial intervention and the management of sepsis. Thank you.
Thank you. Thank you very much, Dr. Walsh. We are welcoming Dr. Seitz, specialist in internal medicine and infectious disease in Vienna, Austria. So she will be discussing the role of rapid culture-independent diagnostics in serious COVID-19 patients.
Thank you very much for the kind introduction, and thank you for the opportunity to share with you a clinical experience with the T2MR. So, like said, I'm working in intensive care unit, specialized in infectious diseases in Vienna, in Austria. And since the beginning of the pandemic, we're taking care of patients with severe course of COVID-19. So quite soon we realized that there's a really high rate of bacterial and fungal superinfection, but it can be quite challenging to diagnose them. So this is why we decided to implement a non-culture, as a culture-independent method, and we decided for T2MR because it's easy to use and it is located in our department, so we can use it as point-of-care method. So if a superinfection is suspected in a patient at the intensive care unit with COVID-19, the physician in charge is performing the standard of care, for example, the blood cultures, and at the same time is doing himself or herself the T2 Candida panel or the T2 bacteria panel. So after 60 patients with suspected superinfection, we did an analysis to evaluate the benefit of the T2MR. At total, 85 times a superinfection was suspected. The mean age was 58 to 59 years of the patients. 26.7% were female, and most of them were ventilated. At first, we compared T2MR and blood culture. So if you're looking at the T2 bacteria panel first, the E. coli and Staph aureus was detected once in T2MR of the 85 times, and both of them grew in blood culture as well. Klebsiella pneumonia was detected twice and only once in blood culture. There was no Actinobacter baumannii, but there were 5 times Pseudomonas aeruginosa and the Enterococcus faecium, and none of them grew in blood culture. Of course, in blood culture, more pathogens can be detected, and in 2 cases, so twice, pathogen was detected in blood culture that's not included in T2 bacteria panel. So it seems that the T2 bacteria panel is more sensitive than the blood culture. Anyway, the results are more impressive in the T2 Candida panel. So of the 60 patients, 8 times a Candida albicans or tropicalis was detected in T2MR, and there was no growth of Candida in blood culture. And once there was a Candida parapsilosis in T2MR and in blood culture. So the next thing we wanted to see is the time until the detection of pathogen comparison T2MR and blood culture. And it took about 3 to 5 hours to get the result from T2MR, and it took over 50 hours to get the positive result of the blood culture. So the next question we ask ourselves is whether there's any clinical benefit for using the T2MR. And actually, it was possible to change the therapy in 15.3% after we got the result of the T2MR. And mostly it was an escalation, but in 23% it was also a de-escalation. So we could reduce the use of broad-spectrum antibiotic therapy and really start a targeted therapy. On the meantime, until the therapy change was between 7 to 8 hours, so we could prove that the T2MR is really a point-of-care method, and we can change the therapy on the same day. So next, I brought 2 examples, so you have a little bit of an insight of the work we are doing. So the first one is a 68-year-old woman with diabetes, elevated blood pressure, and a little bit obese. She was directly admitted to ICU with COVID-19 and respiratory failure. She has to be intubated quite quickly and mechanically ventilated. At first she got better, but the weaning was prolonged. And in the meantime, there was an elevation of cholestasis parameters and inflammation parameters. Fever spiked, and the clinic was deteriorating. So at first we did an ultrasound of the abdomen, and there was signs of cholangitis. So we started a broad spectrum antibiotic therapy, but the patient got worse and worse. So we did a CT, and here you're seeing liver abscesses. Then we decided to do a T2 bacteria and Candida panel, and in the T2 Candida panel, a Candida albicans tropicalis was found. So at first we started the antifungal therapy, and actually the patient improved. Of course, we did the ERCP as well, and a lot of samples were collected there, and there was a crew of Candida albicans either, so it was a confirmation that the T2 Candida panel was true positive. The second patient was a man, 53-year-old. There was no history of chronic diseases. He was admitted to hospital 8 days after symptom onset of COVID-19. Actually, he deteriorated and was admitted to ICU. He had to be intubated. The weaning was complicated by a ventilator-associated pneumonia. And we did a T2 bacteria panel, and a Staph aureus and E. coli was shown. And then in the BAL, a growth of Staph aureus and E. coli was shown as well. But of course, the culture of the PLL took a couple of days. So in this time, the T2 panel enables us to start the therapy, the targeted therapy, earlier. So the patient improved under therapy, but then he deteriorated again and got a septic shock. At this time, he got really a broad-spectrum antimicrobial therapy, had a lot of side effects, for example, an elevation of the liver parameters and cholestasis parameters, but we didn't find any pathogen. So there were several blood cultures, BAL, urine, there were no growths. So we decided to do the T2 bacteria panel and Candida panel because it seems to be more sensitive, and there was an Enterococcus faecium detected. So we started a targeted therapy, we moved the central line, which was thought to be the focus, and we did the ultrasound of the heart, and there was an endocarditis of the aortic valve. So we knew he had to have a really long duration of therapy, but actually the liver parameters were decreasing because we were able to just use the targeted therapy for the Enterococcus faecium, and the T2 bacteria panel was the only method we could find it. So he improved, and he was discharged to rehabilitation after 42 days of ICU. So this is my last slide. So in my experience, there is a benefit of additional use of T2MR in patients with severe course of COVID-19, because the T2 Candida and bacteria panels enables, compared to the gold standard, in our case the blood culture, a more sensitive detection of pathogens, and shorter time until detection, and an earlier and more frequent targeted therapy. Anyway, it has to be mentioned that the blood cultures and the culture of other sites are still needed, because of course there can be detected more pathogens. For example, the Aspergillus complex, which is a big topic in COVID-19, and we have the antibiogram there. Thank you very much.
Thank you very much. So we have about 10 to 15 minutes of discussion. Dr. Zeit, maybe you can come actually sit right next to me so that we can discuss on the other speakers are online. So do we have any question in the audience? Yes.
Hello, hi. Giorgia Caruana from Lausanne, Switzerland. I was just asking, wondering, actually I have many questions, but I will limit it Just asking, when you assessed the blood culture, did you assess also polymicrobial samples? And what happens if you have a polymicrobial infection? And the other question is this technology applicable or will be applicable in the future to other samples than blood cultures? Thank you.
I think the second question is better for Aparna.
Aparna, do you want to answer this question?
Yeah, so for the first question about antimicrobials and how exactly the testing was done, I would like Dr. Walsh, who's been the PI on all the studies he mentioned, talk more about it from his clinical perspective. Dr. Walsh, please.
Yes. Are you able to hear me?
Yes.
Yes.
Very good. So as I think taking the first question, the question is, what is the impact on polymicrobial infection? We need to recognize that, for example, T2 candida and T2 bacteria have a limited repertoire that represent approximately 90% of the pathogens causing candidemia or bacteremia, but nonetheless, one can have a variety of anaerobes, one can have gram-negative pathogens that may not be on that panel, many gram-positives as well, Viridans streptococci, for example, Enterobacter species. And it's to underscore that the T2 candida and the T2 bacteria are to complement blood cultures. The two can be seen as complementary systems, not competitive necessarily with each other. So as a standard of care, we advocate both the T2 system and conventional blood cultures. That which T2 bacteria may not be able to detect, conventional blood cultures will detect, albeit delayed. And then one can further adjust therapy. So a polymicrobial infection is a challenge, but certainly for some of the major pathogens that constitute a polymicrobial infection and can be the drivers for ultimate septic shock and high morbidity and mortality, the T2 bacteria is still detecting them. And then for candidemia, you may have candida plus positive bacteria, but certainly for the most common species of candida, we're able to detect those.
Thank you.
Thank you very much. We have another question.
Hi, can you hear me? Yeah. I'm a neonatologist. I work in neonatal intensive care in Italy, and we regularly use T2 bacteria panel. My question is, have you experienced any experience about the persistence of the positivity of T2 bacteria panel? We know it identifies live microorganism, but we had the case of an infant with a regular persistence of Staphylococcus aureus after targeted therapy, and we have the problem of the blood culture that often results negative, probably because the low quantity of blood amount that we take from our neonates. And if we had at the start of the therapy, a blood culture negative and always negative, positive T2 panel, it's difficult to understand if we have still a positivity or not. I don't know if...
Yes, Dr. Walsh, would you? Yes, Dr. Walsh.
So for clarification, you touch upon a very important point, and that is the volume of specimen, whether by blood culture or by T2 bacteria or even T2 resistance. For the T2 system, there is a certain minimal requirement that's used for the molecular reaction to occur. Without that minimal volume, then you do decrease the sensitivity. The T2 Biosystems group has been working to try to identify smaller volumes. There was a paper from Children's Hospital of Pennsylvania, of Philadelphia rather, that identified smaller volumes in a oncology and critically ill pediatric population, albeit not so much in the neonate population. Obviously, in low birth weight infants, our volumes are even smaller. But if we were to, and so therefore the sensitivity of everything is really reduced. But if we were then to think about the question that you're asking, what happens if we still, in that subpopulation, have a positive T2 indicating resistance and a negative blood culture? I think the weight of evidence would say that we are still able to detect small amounts, literally down to a lower limit of quantification of detection of one organism per ml, which may not be enough for conventional blood cultures, that if we are coming up with a positive signal for resistance or organism, I personally, in my own clinical experience, would take that very seriously and treat on that basis.
Thank you.
Okay, we have another question over here.
Yes, I have a question concerning the diagnostic strategy. So if I understand it right, you have 3 different panels, one for Candida, one for bacteria, one for resistance. And if you have now a patient you want to test, what do you start with? You use the bacterial panel first. If it's negative, you use the Candida panel. If bacteria is positive, you use the resistance panel. Or what is your suggestion?
Dr. Seitz?
So in our department, we didn't use the resistance panel because in Austria, we are quite lucky to have a small rate of antimicrobial resistance. But actually, I would start with the T2 Candida and bacteria if it's positive to do the resistance panel afterwards. If the patient is in septic shock, of course, you can do all of them together. But yeah, you have to be choose it wisely when it's necessary, because of course you have to consider the costs as well.
And how many tests can you run in parallel on the machine?
Sorry?
How many tests can you run in parallel on the machine?
7.
I think we have a question here first. Yeah.
Hello, I'm Dr. Roxana Filip from Romania, and I have 2 questions. First question is, have you done the correlation between the antimicrobial stewardship program and the results obtained after using T2 system? I mean, in 5 hours with T2, you can target your therapy and decrease antibiotic consumption. This is the first question. And the second question, I have seen in one patient that you have presented, the one that I think died with the septical shock syndrome. Have you tested any other sepsis markers for him, like, for example, procalcitonin or CRP, or let's say the hotspot of nowadays, PSP? I mean, what about if you have any information on PSP? If you use it and if you have any information on that?
That's a really good question, thank you. We didn't match we didn't evaluate the antibiotic use, but we are planning to do that. So we are planning to evaluate whether it's a benefit in reducing the antibiotic, the broad spectrum antibiotic
because
therapy.
let me make a short comment, because in our hospital we are doing this, and let me tell you that the input is very high because there is a big decrease, financial decrease in costs on antibiotics, because it's 2 or 3 days of antibiotic empirical therapy, which now in 5 hours you can have a target therapy, even if you have the Vim or Klebsiella pneumoniae enzyme or other enzymes.
Okay, that's interesting.
And another question is, how do you select the patients? Because in my hospital you have a formula with Q-SOFA, SOFA, and other criteria, because patient has to meet some criteria to do the T2, because it's an expensive test and we can't do it for all the patients, at least in my experience.
Yes, that's absolutely right. In our case, we are Department of Infectious Diseases, so I think our colleagues are really choosing wisely when to use it and when not, but we don't have any strict criteria. So it's more like in the physician in charge is deciding to use it or not to use it. But we saw retrospectively that it's really only used if it's necessary, maybe even not often enough. And to your other questions about the sepsis parameters, we are using CRP every day, and we are using white blood count every day, so we're seeing that, but we're not using procalcitonin. So it's not common in our department. But in all patients, we concluded there was an increase in inflammation parameters.
Okay, thank you.
Dr. Walsh, did you want to add anything to any of these questions?
Yes. I thank Dr. Seitz for her insights and valuable clinical experience. And to answer the question of how T2 can be utilized, we have taken several approaches, one of which is for Candida to identify in which units do you tend to see the highest burden of Candida. Obviously, candidemia is a major problem, but in trying to have good diagnostic stewardship, we focused on the medical intensive care unit as a model. However, one can, in other institutions, that may vary depending upon the given sites. Surgical intensive care unit may also be, even neonatal intensive care unit. Much of it depends upon the use of prophylactic azoles. So, for example, in our oncology and stem cell transplant population, where we use aggressive antifungal prophylaxis, the burden of candidemia is considerably less. That isn't to say fungal infections aren't important in that population, but the impact of candidemia was less, so therefore we focus on medical intensive care units. In other settings, however, I've spoken with other colleagues, and they have expanded T2 Candida into other units based upon the burden in that specific unit. Similarly, it pertains to T2 bacteria, where in a number of institutions where T2, of which I'm familiar, T2 bacteria was targeted to stem cell transplant, leukemia, high-risk hematological malignancies, and of course, medical surgical intensive care units.
Thank you very much. So we have another question over here.
In view of the high analytical sensitivity of the T2 system, did you consider transient bacteremia in those cases where there were discrepant results between culture and T2 result? I mean, did you always treat?
Yeah, actually we talked about that. And in most cases, we have a confirmation later, so that the bacteria, the Candida was in any other culture. But was actually what was.
Or did you repeat? Did you repeat it with other blood cultures in order to strengthen this discrepancy?
Not always, actually. But what was really interesting, we diagnosed a lot of pneumonia. So normally ventilator-associated pneumonia, and the blood culture was negative. Mm-hmm. And for example, Pseudomonas was detected in T2MR. And the Pseudomonas was detected in BLL as well. So we can discuss, maybe it's not a blood culture infection, it's just a trace of the Pseudomonas. But in our case, there was also a clinical need to treat it. So urgency. We decided to take it for 2 years.
Thank you.
Thank you very much. One more question, yeah?
Yes, thank you. My name is André Fuchs from Germany. I'm an ID specialist, and my question goes a little bit in the same direction. From your talk, Dr. Seitz, there was one patient with Staphylococcus aureus pneumonia, and you detected from a blood sample Staphylococcus aureus. How did you interpret this result? Did you interpret it as Staphylococcus aureus bacteremia and decided to do a prolonged treatment course, or did you treat as pneumonia? And why?
That is actually a really good question we asked ourselves. We decided to do blood cultures quite often and to repeat it before starting the therapy and then just treat it a short time. So like it's a Staph aureus pneumonia. But I don't know whether that's the right thing to do.
Any more question? Dr. Walsh, Aparna, do you want to add anything else?
Well, I would also say that when we speak of, in reference to the prior question, what we have learned from Candida, for example, of transient candidemia we always have to be careful in terms of the sensitivity of blood culture. Certainly, we learned from candidemia, where there was a sense that if one only had one positive blood culture for Candida, that historically that was often trivialized and said, well, not to be important, it wasn't important, and one, therefore, in the absence of a second positive blood culture, many patients were not treated. Now, we no longer do that because we have, sadly, autopsy studies, we have outcome studies that show that one positive blood culture may signify extensive, deep burden of infection, and that the number of positive blood cultures may not necessarily signify the burden of disease. And so certainly with candidemia, even one positive blood culture would warrant a treatment for a definitive course at bare minimum 2 weeks. For Staph aureus bacteremia and with pneumonia, it becomes more difficult, but certainly the concept of transient bacteremia, for example, with Staph aureus, is one that needs to be held with a considerable concern in the absence of another source, that it might be real. And I think T2 being more sensitive may usher in potentially a new way of understanding that many of the transient bacteremias may actually be real deep-seated infections.
So thank you so much to the speakers and my co-chair, Dr. Sarah. Dr. Sarah, would you like to close the session?
Thank you very much. Thank you, everyone, for coming and listening to this session. I wish you a pleasant rest of ECCMID.